Dr. Walid Al-Kredi, Director of Home Health Care Administration, Ministry of Health, Saudi Arabia, and Dr. Deeb Al-Qahtani, Chair and Founder of Integrative Health Organizations, Saudi Arabia. So let's start off this conversation with really trying to focus on the importance of establishing a research ecosystem and infrastructure. I will start off with Dr. Nof Mir, and this is specifically throughout your experience and throughout the roles that you play today. What's the importance of having a research ecosystem? That's one. And how do you envision prioritizing on a national level to address this global challenge today?
Okay, thank you. Thank you so much, Dr. Haya, for the invitation. It's an honor to be part of such esteemed panelists and to discuss also such an important topic. Research ecosystem is very important for a policy development, and I will answer this question from the perspective of health and all policies. And for the audience here, let me first maybe introduce the health and all policies approach. It's a collaborative approach that sets health, equity, and sustainability across all sectors. So we are not looking at the health within the healthcare sector only, but we are looking at within the education, within the environment, social, economy, food, sport, and so on. So this is what we do in health and all policies. In the kingdom, we are governing health and all policies at a higher level, so it's embedded within the central government. We have a ministerial committee looking at this topic and exercising this topic. We have the support of 11 ministers with us for activating health and all policies in Saudi Arabia. So from health and all policies, an ecosystem or a strong research ecosystem is very important because it informs the policy development. And we look at it as the first step. So after setting the priorities or understanding the priorities out of the research, we build and start to understand, build our understanding around, the challenge or the problem that we are trying to fix or mitigate or be proactive in solving it using the policy, not just the initiative and programs. From my own experience as a scientist and from the role that I'm taking now in health and all policies, I think 5 main points important to build an ecosystem or a strong ecosystem. First is a governance, a very strong governance and alignment where we set the research on the national strategy. 2 is building capabilities. So investing in the workforce, investing in the futuristic jobs within the research environment and in the ecosystem. 3 is funding mechanism, having a very clear funding mechanism that will help us setting the priority and activate all the researchers, the scientists, the great brains around us to be part of such ecosystem. So we say the governance, building capabilities, funding and infrastructure. 4th is very important. So having a data and digitalizing digital infrastructure is very important as well. And the 5th is having a platform, a collaborative platform, where we can shorten the distance between the sectors. And this is what we do in health and all policies, trying to acknowledge the interdependency between different sectors and trying really to set a platform, a collaborative platform that all the sectors sit together, discuss, and work together toward one vision.
Thank you. Thank you, Dr. Nof. This takes us to a very important step. We've got a very good panel here, from public health to research to private sector to more population level collection of information and data. I'll transition to more of the essential elements that you need in developing an infrastructure that supports research from a translational perspective. We've got the Saudi NIH with us today. In your personal opinion, what's key to develop a research ecosystem that informs policy? What's important? What are the gaps? And how do you specifically in Saudi NIH address them?
Sure. First of all, thank you, Dr. Haya, for the invitation and to be among the panelists. Actually, we are talking about essential elements. We are talking about the whole infrastructure. So building infrastructure from scratch, we have to consider many things. I think one of the most important things is to change mindset, culture. This is the most important element to start with. And then we start talking about the other elements, which is important. Having vision, for instance, and a strategy with setting up milestones and measurable goals. Second is to recruit high talented and expert scientists in this. One of the important also things, because of the nature of the Healthspan research, it needs a collaborative approach. It needs, it's a teamwork, in fact, between scientists and clinicians. So this integration between scientists and clinician doesn't exist yet. So what we need is to have more collaboration, integration, and maybe more advanced into recruiting high talented scientists from abroad to embed this practice and this culture within the system. One of the also important element that we have to consider is utilizing the AI and the big data to build a robust data set for our community. I think everybody knows and appreciate that without having a robust database for our community, we cannot have a strategy, we cannot have a roadmap, we cannot have even planning, efficient planning and funding. The other also element to have not only having funding, but sustainable funding. I think this is something important because when we set up the infrastructure, we have to make sure that we secure the fund for the whatever elements needed to continue, because the health span and the longevity research is not a short-term research, it's a long-term research, which requires to keep the momentum and to keep the interest of all stakeholders involved. So having a sustainable funds is really important element. Probably one of the elements, building the workforce and the manpower as well, because again, without having enough training of the practitioners, involving them in what we call evidence-based practice research. This require, again, as I mentioned, it's change the mindset and their culture to keep this the health span research in their mind while they are practicing, while they are seeing elderly people, while they are treating and managing geriatric patients. I think this is something important to keep in mind when we are talking about the infrastructure.
Yeah. Thank you so much. But this takes me to Dr. Deeb. He's the only one from the private sector here. So we'll be asking you a lot of questions related to the private sector. You've mentioned a lot of your interest today is how do you integrate latest tools and technologies for research purposes that will enable data development. Can you just give me some of your insights from that perspective and how important it is within the ecosystem that the GCC is thriving and is wants to develop?
Sure, thank you very much. Actually, I always look at the healthcare system from three different angles. I'm speaking now as an entrepreneur or as an expert from private sector. First one is from the health finance perspective, as an insurance company or maybe in the future a national insurance program, or and how we can move and from an insurance benefit that only focus on essential health benefits to become a longevity benefit one day. And this is when we look at it from healthcare financing, let's say, perspective. Second one is as a provision of healthcare. Provision of healthcare can be hospitals or clinics or labs or pharmacies, and how we move from being a traditional network of healthcare that working as a silos to become an AI-driven healthcare network, consider the longevity and health span as a core of the networks, which needs something, we name it maybe an inclusive ACO. And the last one is as a life sciences company and AI companies. What make us interested in conduct our R&D in Saudi Arabia, and then how we can make our healthcare system attractive to clinical trials and AI companies. From these three angles, I can say I'm very optimistic that healthcare, especially in Saudi Arabia, in the right time, because the national driver push us to invest a lot in the infrastructure of IT, data, and etc. And considering from the early stage of transformation, the initiatives that can enhance the AI and data and real-world evidence and etc. It's critical to be considered right now by regulatory and by even payers, etc. So I can say this is the three perspective that I can see it. Yes, how we can move from being an acclaimed data center to become a longitudinal medical records integrated to a data lake that help our country to build their strategy in longevity or any national initiatives. This is maybe the three pillars that I can see it. It's an area that can private sector be a part of it from different angle, from insurance, from provision of healthcare, and from the life science and AI companies.
So going from your point, the importance of AI and healthcare and insurance, how does the Ministry of Health make use of this research ecosystem? How do you take this information to the consumer or to the general public?
Okay.
How do you prioritize things, and how do you use influence-based policies to drive the future strategy of the Ministry of Health?
So first, thank you, Your Royal Highness, for inviting me with the esteemed guests. So for us, basically we take a holistic approach when we address healthy longevity and lifespan. Basically, our North Star and our vision to ensure that every individual in our society is not only living longer, but healthier and supported by a resilient healthcare system. Moving towards basically fulfilling our commitment to Vision 2030, especially when it comes to the goals related to the health-related goals. So these are the guiding principles. We want to ensure that we prioritize first prevention, second health transformation and digital transformation, and third to partner with the private sector and engage with them at multiple levels, and finally to ensure sustainability in our programs. The third guiding principle for us in the ministry is to make sure that we are client-centered. As the Vision 2030 put the Saudi citizen at its core, most of our programs are designed and tailored to address their needs. And we understand that for us to address healthy longevity, we really need to understand the regional variations and put that into account. We also need to design programs that meets people where they are at multiple places, and also link this to the priorities that we set guided by our Vision 2030. And we also want to ensure through our programs, again, sustainability. So we want to, this is basically addressed at multiple levels within the ministry. It comes from adapting a resilient programs that basically ensures the putting value in healthcare system, and these core goals and principles are at multiple initiatives. For example, we do that with the value-based program, and we also incorporate that in our contractual agreements, even with new therapies and all initiatives. If you put that all together, through these principles, we want to make sure that the research doesn't stay at the academic level, but moves to the front line. So for us to make sure that this is happening, we set like continuous, basically feedback loops to inform the policies, inform also our programs to help us prioritize which has to take precedent, and we can invest in it in real time. We deal with the clients head on at the front line, so we understand their needs, and through like these feedback loops, we kind of tailor our approach to respond to their immediate needs through multiple systems.
Dr. Walid, you mentioned something very interesting, regional variations.
Yeah.
This means that you have to have a good amount of data that can help you identify these variations, and specifically, and how fast do we age, and when is the onset of age-related diseases. And this takes me to Dr. Rasha. You're looking at it from an even higher level. Everyone that was speaking here was zooming into the kingdom's experience. Can you just give some information about the quality of data that you have that represents GCC? Are we there yet? What's gapping? And what are the approaches from a research perspective to collect this data that can inform policy and hopefully develop interventions?
Thanks, Dr. Haya. I think just to start with a main point, since I'm representing the Gulf region, so I think the representation of the Gulf goes to the similarities between those countries. So whatever we can see in Saudi Arabia, it definitely goes to the other 5 countries. So we have a lot of similarities between our regions, and starting with the demographic of our population. So we have, in fact, a young generation, but this young generation, by time, they are getting to be an elderly population. So starting from here, we see this as a challenge and as an opportunity. Opportunity that we have a time to understand our population more. On the other side, it's a challenge since we are at the meantime seeing the challenges of the non-communicable diseases, the other risk factors. So this took us to identify how we want to work on this and what are the needed data to understand our population more. Talking about the data, so whatever my colleagues here, the panelists mentioned, it goes to the countries. So we have, for example, challenges with the quality of the data and the availability of the data. So we see that we lack the availability of the data, and if it's there, we are questioning the quality of the data. So for that, and again, the data between the sectors, the focusing on the data between sectors, the transition of the data between sectors. So talking about that challenge, take us also to another challenge, which is the systems where we are, having these data, how the other sectors are utilizing this data. So this is again another challenge, which is the system. Again, the sustainability of collecting this data. So for example, for the sustainability, we lack of, for example, some consistent national registries, the consistency of national health surveys, where it is the first channel to have and collect the data. So given those challenges, how we are working with the Gulf region, we at the Gulf CDC, and given our mandate on the working with the Gulf countries. So for example, we started with a burden of disease study where we want to identify and assess the challenges within and the mortality and morbidity causes. So we built this burden of disease study. Then we are planning that we are going to build the capacity of the countries that they generate their own burden of disease studies. And we started now with the countries to train them of calculating the healthy life expectancy. Again, this brings us, okay, we want to calculate the healthy life expectancy. What are the determinants that we want to use for that? So we went to the, for example, for the mortality registries and the gaps in the mortality and the cause of death and so on. So our mandate is to support the countries to strengthen their systems, as well as also the surveillance system and the other data surveillance. We are looking to unify the surveillance between the countries. This will bring us to implement a unified guidelines within the countries. So we know that each country has their own system, but we are trying to support the region with this unified surveillance systems to support that. Of course, this will bring us to the research. So since we are having a good, robust data, then we can utilize it in a good research, identify the priorities in the research. So we think, yes, the Healthspan, it is something new in the region, but with building our infrastructure on that, with identifying our data, we can be a leading in the region for the research and the Healthspan.
Can I just ask you a clarifying question?
Sure.
So you directly work with the Ministries of Health
Yes.
in the GCC regions?
Yeah, so we work with the Ministries of Health and we work with the public health authorities. So for example, in Saudi Arabia, it's the only country at the meantime in the region that we have a public health authority. So we work with the Ministries of Health and the public health authorities whenever it is existing. Again, through the Ministries of Health, we work beyond the Ministries of Health. So we reach out to the other sectors. As we are talking today, all the public health, it goes beyond the health sectors to other sectors, working with them through our ministries.
Thank you so much. This takes
Thank
me
you.
to, you mentioned registries.
Yes.
You mentioned national level. You mentioned impact. And this takes us to the other point that we want to discuss today is impact funding. So what are the right models to fund large-scale research, collecting good quality data? So I'll ask Dr. Nof, starting off with you. How can we build a sustainable funding model that can support health research from your perspective?
Thank you, Dr. Haya. And I really enjoyed the answers from the first discussion. And I agree with most of the challenges that's been discussed. And this will help me answering your question regarding the funding. And I will again answer it from the health and all policies perspective. So it's not just healthcare or health ecosystem. I do believe that it should not be a responsibility of the healthcare or health ecosystem only. It should be a shared responsibility. 80% of the impact comes from the non-healthcare sectors. So we should activate the research in the environment, the education, the economy, sport, food, and so on. So if we put this in our minds, then it should be decentralized. All the sectors take care of the research that they are mandated to do. This aligned aligned with our strategy, the health and all strategies, because all the sectors are mandated to propose policies. And for that, they are mandated to do the research to support the development of the policies. So from the point of health and all policies, we think that is a shared responsibilities and a mechanism that suits each sector should be considered within the sector, building the capability needed in the sector, building the infrastructure needed in the sector, in a different sector. This is how we see it. Then having this calibration or a platform that connect all the sectors together and discuss the challenges. And again, I do agree with Dr. Rasha, challenges are opportunities for us to innovate and to move our researchers to propose solutions. Although funding is very important, but before funding, I think setting the priorities is something really important as well to activate the funding toward the priorities. At this time, we are looking at the priorities in the national level. We are still reactive, not proactive, because of the data. So we can't predict the futuristic burden of diseases and acts, toward mitigating it. So setting priorities as well before, discussing or locking the funding mechanisms is a discussion that we are having now, not just in the national level, also in the regional level and an institutional level.
This takes me to Dr. Deeb. How do you envision private sector and public sector collaboration in funding research and funding development of good quality data?
Great.
How do you bridge? What is the important role? And I just want to highlight to the attendees today, I think this region is transitioning today from more of public sector funding to slowly, and I want to highlight this, slowly private sector. I want to hear your views on the importance of private sector participating in developing research that can enable the mission of the summit today.
100%. Let's agree on this. The ultimate goal is to build a unified healthcare ecosystem. But I always like to start from the grassroots. The main issue right now is the integrity of data, the infrastructure of our healthcare facilities in general. When we talk about the data and the healthcare system and the quality of documentation and the coding, and yes, we are in the right time. The government start to push the whole industry to become more standardized, and they consider the documentation and etc. But my simple initiative is to enhance and facilitate and help the healthcare facilities, authorities, insurance company to build their real-world data unit. I think this is the first step, and this is where we have to start as a private sector, is to help the hospitals, again, insurance company, to invest on their real-world data. And then we can think vertical and horizontal. Vertical through what's kind of data that we are looking for from them. From this infrastructure, we can leverage the AI and other digital twinning and real-world evidence and national level, etc. But this is the first step. And building this need, of course, and someone to finance it. It's costly. It might lead to inflation. It's better to build like a fund. This fund can be a private fund. It can be whatever. People in the investment industry know how they can structure this kind of fund. And the limited partner can be either semi-governments or MBO or the grants or whatever, to enhance the whole system, to invest on their real-world data and be able later on for the next level, how we can build a platform for data sharing and other initiatives that help our country and nation to consider the longevity and their vision 2030. So I think this is from my humble opinion, this is the way that we should focus on private sectors. And I always say the private sector is the best entry. Less politics, less bureaucratics, easy to collaborate and build the proof of concept, institutional level, and then on the private level, and then on national level. And why not on regional level one day? But I always say this is the first step, and how we can finance it. This is a big question that we might need leader and stakeholder to think about it, to deal with it as a national initiatives, and hope the private sector one day will be part of it. We can share the data between the insurance company, hospitals, clinics, and the life science and AI companies can have access to a real, clean, and accurate data. And also the policymakers, they will have access to a good and with a good quality integrity data or whatever. I know I'm a physician, and maybe my understanding for the IT and bioinformatics and this kind of field is quite difficult, but this is the right direction. Always I want to mention that as a good example to inspire from is the Wasfati platform and the Nafis platform. It's really helpful, and it shows how easily we can change the culture of our industry. Once it's become a mandate, all healthcare facilities, insurance companies, and all ecosystem start to consider the claim data. The question and the second step, how we can move from being a claim data centered health information system to become more sophisticated healthcare infrastructure for data, etc.
Yeah, thank you so much. I think we transitioned from the importance of infrastructures to how do we enable funding to get good quality data. Now we're transitioning into outcomes. Let's assume that we have a scenario today and we've identified good data. I'm just putting in an ideal scenario. We've identified good data. This data is ready to take action. From each of your perspectives, how would your different experiences and entities take action? And is it easy? And do we have that infrastructure to do so? So I'll start with your expectations from the activities of the Saudi NIH. Let's assume you supported research, you got important data, outcomes. How can this be applied in real life?
Great. Just to remind you about the role of Saudi NIH in the country and the mandate of the Saudi NIH, which is to sustain, to build, enable clinical trials and translational research. So within this scope of the mandates of the Saudi NIH, I think this can be one of the mandates. And when we built the strategy of Saudi NIH, it was based on 4 pillars: enabling clinical trials, fund translational research at all levels, in all 4 tiers, knowledge transfer into a product, which is exactly answering part of your question, and then transferring this to the community. So if we consider this strategy of the Saudi NIH in terms of transforming the data and the work into a product, this is what we are aiming at. So within this scope of mandate of the Saudi NIH, we are focusing all our efforts in terms of funding, creating policy, even setting up a partnership with and collaboration with international sectors and facilitate this collaboration. This is what we are aiming at the Saudi NIH. So whatever it takes to build a robust system and strong infrastructure to move forward to the next step, the Saudi NIH will take this initiative. From what we have been doing right now in collaborating with the stakeholders at a national level for now and getting their feedback, we are building our strategy around the research programs. And one of the research programs is going to be the health lifespan. It is going to be, it is not yet in the map, but it is going to be in the roadmap of the Saudi NIH for funding, for support, for even setting up, I would say, setting up a structure for moving forward in this direction.
Thank you so much, Dr. Majid. Dr. Rasha, a question for you specifically. Let's assume you've got genetic data, environmental data, that's ideal, how does your institution take or enable decision making and make use of this data to impact the general public?
Thanks, Dr. Haya. So I think, yes, we agree the data, it's important. So now we have the data. What shall we do with this data? I think having or utilizing this data, it goes for different aspects. So first of all, as you mentioned, building the policies and how we are translating it to policy. The second thing also, which is I think an important area, which is the monitoring and evaluation. If we don't understand what we are doing with our projects, with our programs, with our policies, we cannot move a step forward. So today, this morning, I was discussing with the UNICEF and the WHO and the region. We have a meeting about the obesity, childhood obesity. This is just a small example about how we are utilizing the data. You cannot imagine the tremendous efforts from the region, from all the countries, tackling the obesity as an example, yet we are not reaching our outcomes. So where are the gaps in there? Yes, we need to understand more based on our population, based on our needs. What are the needed gaps that we need to close them? So utilizing this data, it will take us to the second level, which is the generating the policy. Given our mandate, we worked with the countries to have a joint policies on a regional level. These joint policies, it will enable us to tackle those gaps, utilizing the data we have. Also, we are building a systems of monitoring and evaluation to evaluate our interventions, to evaluate our outcomes. So putting them all in one system, in one platform where everyone can utilize it, everyone can monitor their work, and to understand where we want to move in the next steps. As well as a registries, we have a unified registries as well as these data from the registries. It will envision our next steps, how to tackle our challenges and our issues within the different diseases, whether it is risk factors, genetic diseases, whether it is road traffic accident considered as a high burden of the mortality in the region.
Thank you so much. This takes me to Dr. Nof. Can you give us a real-life example of some policies that have been developed in health and all policies that actually was an outcome from research? Just a general example.
Well, I'll share, with you some of the policy that's already been activated. So cardiovascular diseases being identified as a burden of diseases, the top burden of disease in the country. And of course, we don't target just the cardiovascular diseases, but we target the risk factors and the drivers behind it. So one of the risk factors is the high blood pressure, that it got influenced by the salt intake, the daily salt intake. SFDA works on a policy to limit the salt in the bread in the country. And with that, we are reducing the salt intake for the population, and which will impact the hypertension or the high blood pressure, and eventually will reduce the cardiovascular diseases. Such policy, we link it from the risk factor or the drivers until the burden of diseases, which eventually reduce the years that we spend unhealthy, and increase the healthy life expectancy and the life expectancy in the country.
That's thank you so much.
May I just echo
please.
Dr. Nof again around these policies? So again, this is a policy that's driven by Saudi Arabia, and it is on a regional level. As well, we work, and this is part of the example of the joint policies that we are working based on the data. We are working, and we have with the region a policy regarding banning the advertisements for children for unhealthy food. So this is, again, another example where we have the data, and it drives us for the policy, and it is on a regional level.
We're hopeful that we're going to get more data that informs us to make decisions in terms of Healthspan. They're great examples, but we're hoping to bring it to life through a collaboration between government, policymakers, and private sector. Final question for you, Dr. Walid. So from a national perspective, healthcare perspective, how dynamic are you as a Ministry of Health to make improvements in how you deliver healthcare and healthcare systems? Is there a plan? We'd like to know more about it, and this is going to be the final question for this session.
So first, I would like to remind everyone about the scale and the speed the health care transformation is going through. In Saudi Arabia, it's the largest in the region, if not in the world as we're speaking right now. At the core of this transformation, we depend on basically being data-driven and developing a sustainable ecosystem to drive our decisions. For example, like we have one of the biggest virtual hospital that monitors and looks after Saudi citizens across the region, and that creates a lot a real-time data that we are also analyzing and trying to help improve accessibility to care. So with this, knowing where are the deficiencies, the gaps, we design programs and funding programs to basically reach people where they're at with the enabling technology. On the other side, I have to say that it's really important for us to understand that we are really scanning for any new advances in technology, and also, again, trying to make sense of all the development that happens on the research side. So from our perspective, we truly want to have a seamless integration into first care delivery, setting best practice guidelines, and ensuring that our monitoring and auditing is also in compliance with these advances. So we keep updating all our policies and guidelines continuously. In fact, tomorrow I have to update the vaccine guidelines for home care and all the adults just to keep up with the rapid development in that area. On another side, maybe my colleagues is sitting in the third row there, he conducted a study about the percentage or proportion of inappropriate use of medication for older adults. So through that study, it was adopted by our Deputy Dr. Tarif Al-A'ma, who influenced the Data and Command Center to initiate a platform to monitor all the inappropriate medications for older adults across the kingdom, utilizing the data coming from either Wasfati or any other platform. So that's a real example of seamless integration that helps us not only change our practice, but to also help us monitor and influence the frontliners to improve care and ensure that they are bringing the best practice to their to Saudi citizens across the region.
Thank you so much, everyone. I think we're a couple of minutes beyond the time. I would like just to tell everyone that's sitting here, you can see examples of how a lot of our efforts in the region are integrated. I think we need to shift our thinking slowly from sick care to more preventative care. How do we develop policies? How do we develop collaboration between the private sector? How do we develop registries? How do we enable data-driven outcomes in the region, focusing on preventative care and focusing on Healthspan? So I'm hopeful that this is just the beginning of our conversation today. Please, you've got brilliant panelists here, so please engage with them, and I'm hopeful that this session will open doors to a lot of collaborations beyond the panelists here. So thank you so much. This has been very informative, and I really appreciate it. Thank you.
Shukran.
A Healthspan focused care delivery model. So let's start today by kind of going around the room. I'd like to introduce all of our panelists. First of all, we have Dr. Ihsan Al-Marzouki. He's the co-founder and managing director of Glue Care Health in the Emirates. We also have Dr. Joseph Antoon. He's the CEO and chairman of El Nutra in Los Angeles. Dr. Wadha Al-Mufta, Senior Director of Qatar Genome at Qatar Precision Health Institute. Dr. Nawal Roy, founder and CEO of Hallmusk in the United States. Dr. Ryan Hurt, who's a consultant and professor of medicine and the vice chair of general internal medicine at the Mayo Clinic in Rochester, Minnesota. And finally, last but not least, Nathaniel Farouz. He's the managing director of Keppel Senior Living in Singapore. So we have a wonderful, diverse group that's going to bring a variety of perspectives to this discussion. And I'd like to start out our discussion here today by kind of going around the panel and ask each of you to give a little bit about your background, the organization that you represent, and the perspective that you bring to this conversation.
Thank you, Michael. And thank you, everyone, for attending this event. I see very few people are coming in, so we're going to give you the secret for longevity. It's going to only be said here, and everyone else is going to miss it. I started as a physician, and a little bit like the questions you're going to listen to today, started in medical practice. The traditional one went into prevention, then went into longevity. I'm actually the founder of the Global Healthspan Institute back in 2012. So it's really nice to come and see here in the middle of Saudi, the Global Healthspan Summit happening here. Today I lead a company called El Nutra. L is for longevity through nutrition. And our goal is, since food is the only product we put in our body every day of life, how can we tailor food as medicine? How can we tailor food as longevity? Appreciate it.
Thank you very much.
Yeah, thank you, Michael, and thanks for inviting me to join today's event. My name is Wadha Al-Miftah. I lead the Qatar Genome program under the Qatar Precision Health Institute. In Qatar Precision Health Institute, it is based on the foundation of the data collected over the past 12 or 15 years through the Qatar Biobank and Qatar Genome. And currently, Qatar Biobank and Qatar Genome are fully integrated under the Qatar Precision Health Institute, leveraging the wealth of data collected over the past years, the data that have been transformed into research publications, and now moving from the research publications and data collection, widening the scope to translate the research outcomes into clinical application through a personalized approach. So focusing mainly on Qatar genome, we are working basically on three main pillars, ensuring the continuation of data generation, not only genome data, but also generating multi-omics data, including proteomics, metabolomics, and methylation data as well. As well as having a main focus now into clinical implementation. And basically, we work with all the healthcare professionals, the academia, the research institutes, in an inclusive ecosystem to translate the research and the data collected from the bench to the bedside. And genomic education is also a big element in Qatar genome. Reaching out to the all level of students, starting from early years until healthcare professionals.
Fantastic, thank you. Nathaniel.
So I'm Nathaniel, I'm French. I've been living in China, then Singapore for the past 15 years, where I've launched multiple concepts of senior living. So you might wonder, why senior living? When you're a senior, isn't it already too late for longevity? Actually, we come from the different approach. It's never too late. And our idea is to bridge the qualitative life outcome we're looking for our seniors: dignity, autonomy, social connection, mental health, bridge it with the science that has been coming up recently in the field of longevity. So we're looking at hardly measurable outcome based on highly measurable input and data. And we combine all this information about our residents to create personalized care plans that help us to increase their health span and their lifespan. So we're doing it in senior living community settings, which you might be familiar with, except you might not be familiar with the way we do it, because we look at ourselves as places where people can age in place for as long as possible. Our ambition, when I say it, might sound a bit underwhelming, but when you think about it, it's not. We're trying to sell normalcy to our residents, allow people to live a life that is as normal as possible for as long as possible. And when we shift the senior living paradigm in that direction, you see that it immediately changes the way people develop, people age, and people become or not become sick. I will stop here.
That's great. Well, thanks, Michael, for having me. I'm Ryan Hurt. I'm a physician by training. I also have a PhD in biophysics and physiology, and so one of my backgrounds is clinical nutrition. So I head up our intestinal failure program at Mayo Clinic. So we feed patients that have intestinal failure. But my bigger role at Mayo is I'm the Vice Chair of General Internal Medicine, which encompasses lots of practices. So we have everything from executive health all the way to long COVID. And now, 2 years ago, we launched our Healthy Longevity Clinic, which I have the fortune of working in as well. And so in that clinic, we try to take a lot of the principles in executive health, a lot of the preventative medicine strategies we do. Our exec health program, we have really good preventative programs there. We hit all the marks for preventative care for those patients. And our Healthy Longevity program really is trying to take that to the next level, trying to introduce novel tests into practice. One of the tests that we introduced into practice 2 years ago is the multi-cancer detection test, right? So we're trying to do cancer interception. We're trying to take the preventative package that lots of patients get across the country and take it up to the next step, and introducing things like multi-cancer detection. We're throwing around the ideas. How can we take advanced imaging into that practice and study it? And so the thing that we've done that a lot of the private longevity clinics aren't maybe doing is taking an academic spin onto what we're doing in healthy longevity, and using Mayo Clinic's, all the strengths of Mayo Clinic to do that.
Thank you.
Thanks.
Isan.
Thanks, Michael. Can you hear me?
Yes.
Okay. My name is Hassan Al-Marzouki. I'm from the UAE. I'm the co-founder of GluCare Health. We're a hybrid metabolic health platform. By hybrid, I mean we cover both the physical and the virtual aspects of care. And just to keep it very, very simple, in a chronic disease, we see patients physically in a location to diagnose, give them pharmacotherapies, But outside, we continuously remotely monitor the patients and focus more on behavioral change. So shifting chronic disease management away from being episodic to being continuous and solely based on pharmacotherapy to a combination of pharmacotherapy and behavioral change. We do this as standard for all our patients, so whether they're diabetic or pre-diabetic or PCOS or obese. We started about 4 years ago. We published a lot of work in this space. To us, longevity, probably the lowest hanging fruit that we can solve in longevity is metabolic health. If you get metabolic health right, and if you have a care model that allows for both aspects in clinic and out of clinic to be the subject of the provider and the provider's responsibility, i.e. collapse clinical and wellness into one and make it the responsibility of the provider, we think we can tackle a lot of the longevity questions and put them into implementation.
Thank you very much.
Hi, it's a pleasure to be here, Michael. Naval Roy, founder and CEO of Hallmusk. Hallmusk is the largest real-world data company that is focused on mental health. My key thinking behind building this company was how do we learn from each patient to make the next patient better? And how do we make data as a key source of utility towards which you can build the science on the back of it? Because as we all know, in healthcare, we understand our metabolic risk to some extent or a great extent, but mental health, we truly don't understand anything. As of now, the endpoints are not well defined. There is a lot of subjective bias that goes into it, and hence there is way too many opinion and not enough science on the back of it. And my whole intent was how to build the science so that it can take it to the next level. Coming back here, I think as the topic of health span or longevity is emerging at a very fast-paced science, I think that is still focused on metabolic risk. And I'm trying to figure out as to how to make mental health and brain health as part of the agenda and part of the discussion, because if longevity has to become not like the current architecture of the healthcare, but literally become the future of healthcare, then mental health needs to be part of that discussion, and brain health need to be part of that discussion.
Well, thank you very much. I want to maybe direct the first question and the first major topic area to you, Nathaniel. And it's how do we think about moving from a disease model of care to a health span model of care? And how do you see that? How do you see the difference? And I particularly given your background and your what you manage and lead, I thought you might have an interesting perspective on this.
So the idea of going through a series of assessment, very comprehensive assessment, then based on this assessment, defining programs, personalized programs, and implementing these programs, then measuring the outcome and updating the assessment and so on and so forth. This is something that has been done in the geriatric care for at least 20 years, if not more. The key difference is that we didn't have the same science, we didn't have the same tech, and we didn't have the same money, the same investment. But the methodological approach has been there. Now we live a wonderful period where actually people in a younger age, at a younger age, start understanding why being comprehensive, holistic matters, why mental health matters. It's not just about this organ or this part of your body that doesn't work. People understand it, money is flowing into it, and we've got tech and we've got science. So I think we're maturing, and this maturation is coming very quickly. But there will always be one problem. Sorry, I've tried to go fast, but it's how do you make people interested in it? We're getting there. How do you make them interested enough so that they change their behavior in a consistent manner? And how do you make them interested enough so that they change their behavior in a consistent manner and are willing to pay for it on a consistent manner? And this is where we still have a few roadblocks, I think. And this is where, again, you need to look at the whole ecosystem, including how you speak with the service providers. Assessment is not enough. You need to implement the plans. And the payers, governments or insurance companies. And I think senior living, we've been at the crossroad of all these ecosystems, insurance, governments. We've got the team, we've got the equipment on site to deliver this preventative care. So now what I'm looking forward is to absorb all your research, all your breakthrough, and being able to implement it for the benefits of our residents. And then why not expand it to younger crowds?
And I think, and that's why I wanted to begin with you, I think what I see in the senior living space is this unique opportunity to really impact whole health, that you have all of those pieces essentially under one umbrella that you can intervene on. It's not just healthcare, it's not just providing nutrition, it's not just the social environment, but it's very, very unique. And so maybe I'll lead this to you, Ryan, kind of going from the, I don't want to say the other end of the spectrum, but from a more traditional internal medicine primary care model. What do you see as the opportunities or barriers that we need to overcome to sort of bridge that, to get the healthcare and the clinical model more into a whole health ecosystem?
Yeah, I think there's lots of factors here. I think the one that I'm probably the most passionate about is the training of our young physicians, right? And how do we train them in medical school and residency and beyond? This model is the right model. I think you're not going to get any argument about that. I think how we train staff, we get so siloed into specialization, at least in the States, pretty quickly, right? Like, I'm taking care of this disease state, I'm a gastroenterologist, and I'm only taking care of that. I'm not talking about the mental aspects of the GI disorder or some of the other factors of the GI disorder, the nutrition piece. We get so siloed into the specialization of medicine, and I think that's one of our biggest challenges. I do think that things are evolving and changing in that I think people are understanding that, just going in and getting your surgery done. Well, there's so much more to medicine than just that one single, disease state issue. And I think as we are now evolving into how Healthspan is really an important piece of medicine, I think that's coming. It's coming from patients advocating for themselves. I often will have patients come in and say, hey, the specialist talked to me about this, but didn't cover my mental health. How am I going to cope with the surgery? Or the nutrition? How am I going to feed myself before and after? And so I think for me, it's going to come from the patients, and in the end, it's the payers too, like was mentioned. That's one of our biggest barriers too, is how is this whole concept going to get paid for, right? Until you start showing quality metrics and outcomes, at least in our country, it's going to be a challenge to get it paid. But for me, it starts with the training of the next generation of physicians, and that I think will help.
Now, Ihsan, you and I have had some conversation about how you've managed, particularly the physician experience and the education and care delivery. In some ways, I see it as sort of an extension of that taking experienced physicians and say, this is the way we want to deliver care, and this is how we're going to shape that experience. Yeah. I feel like you come to it with a little bit of an engineer's perspective on how do we manage that and engineer the experience. Can you speak a little bit more about that?
Sure. I mean, look, none of this implementation is rocket science. If the biggest issue we have in applying, let's say, behavioral change with patients is we don't get reimbursed for it. It's all advice. There's no tracking. There's no responsibility of a provider. And I think the biggest hurdle that we face today for the implementation of this is due to the insurance companies, the payers. They look at 12-month cycles of insurance. So if you want to reverse a pre-diabetic, forget it. There's no ROI to the insurance companies for reversal of a pre-diabetic. There's a huge ROI to the government or to the total system. But look, when we look at something like metabolic health, we can't just focus on pharmacotherapy. We pair that patient with a physician, with an exercise coach, with a dietitian, with a psychologist, with a sleep coach, with a diabetes educator. We give them wearables, and like one of the questions asked, who pays for all of this? If you ask the patient to pay for it, they won't in an insured model. If you ask the payer to pay for it, forget it. There's no outcome-based type of contract that focuses that, at least in the UAE. So it's all fee for service. So we have to pay for it as providers. We have to make it standard. We have to teach physicians how to, read, sleep data from this device, from an Oura Ring, for example. We have to give them the time to allow for it. We have to teach them how to read stress and menstrual cycles, anything that comes from wearables, we have to teach them to do that, give them the time. Again, I think the biggest problem is if we just ask patients to self-manage themselves just through advice, it just doesn't work. And this is why I think, at least in the UAE, 80% of type 2 diabetics are poorly controlled, despite access to care, despite access to the GLPs that we all hear about. How are they all poorly controlled? It's because we're still practicing episodic care.
Well, that leads to, I want to bring in Dr. Wadha, particularly on the genetic end. That's an area that I've often thought about, and it's an opportunity, but also a concern. That how do we deliver the right sort of genetic counseling? How do we pull that into the conversation? I see tremendous risk if we don't do it well, and it's not as simple as I see it. There's a lot of expertise in that cannot be sort of protocolized. Can you speak to that a little bit?
Yeah. I would like first to comment on Dr. Hassan's feedback. Well, we do have an experience in Qatar through a preventive program called the Wellness Program that is integrated within the Primary Healthcare Corporation, which is a structured 12-week program that has people managed by people, a multidisciplinary team, including primary healthcare physicians, clinical geneticists, health coaches, exercise physiologists, and clinical nutritionists. So this program monitor the patients or the public or the community through the medical electronic record, identifying those people and enroll them into the wellness program. And they monitor them over 12 weeks to give them a personalized approach considering their biological markers and the genetic markers that has been provided to them through the Qatar Genome and Qatar Precision Health Institute to develop a personalized approach where this individual who are at a pre-diabetes phase or at the level of developing obesity at the disease state, to integrate them include them into the program and give them this personalized plan. And over the 12 weeks, they receive the coaching, and they use the facilities within the primary healthcare that includes the gym facility, swimming pools, and encouraging them to bring their family members to join such a program. Yes, it is still, the numbers of diabetics is still high, the number of obese patients are still high, but having a holistic approach where we can integrate the genomic data with the electronic medical record and the availability of such preventive approach in the healthcare could help at least manage some cases before the signs or before showing the symptoms of the disease. And in Qatar Genome or in Qatar Precision Health Institute, we tackle precision health at different levels, mainly through the preventive approach and public health approach to manage chronic diseases, and also to look into our data, dig deep into the genome data and the data collected through Qatar Genome and through the biobank to identify those who are at risk of developing certain diseases, and making sure that the healthcare providers are ready to give the right care and assessing the readiness of the healthcare providers to accept those individuals who enrolled on voluntary basis into our research programs.
Fantastic, thank you. And let's speak a little bit about the nutritional side and integrating that nutritional information. You know, when you're taking into account the clinical, when you're taking into account the genetic, how do you see clinicians interacting with this sort of expertise?
Yeah. Well, thank you, Michael, for the question. I want to first second what was mentioned on the health system as well. I had the chance to be an advisor to over 12 ministries of health and to push them towards prevention. And I'll share here the three major challenges that we face to get aging agenda forward. in the adoption. And the first one is, most ministries of health have a budget that can barely hold to cure what's in front of them for the year, right? So the politician's first goal is to get reelected.
Yes.
Re-election means get something done this year and don't get any opposition. They're not thinking about how can I fund something to prevent something not happening in the future. That's number one challenge. The number two challenge is if they want to fund even prevention and or Healthspan, there was no clear product or technologies yet. We're all here trying to come up with those, whether those are programs for normalcy, whether those are integrated programs for diabetes, or what we work on, which is nutrition for longevity. But there was no clear investment. It was up until now education on how to eat, not to smoke, etc., which became a little bit of a commodity. Number three, and probably the most important for us today, and something that I think Hevolution is focused on, is how can we measure health? What is health? Is it normalcy? Is it the biological age of the body? Is it HbA1c? What is healthy? And maybe one of the cornerstone fundamental of Healthspan is to measure the biological age. Because at least we all know that diabetes, cancer, Alzheimer's, they're age-related diseases. And the beauty here, we're trying to slow down aging to prevent all the four killers. So therefore, if you're younger from the inside, the biological age is not the age on the passport, but the age from the inside. If you're younger than your age, I always say stay younger than your age, then probably we gave you just a few years of health span. And so I see that policy is now excited to pay, but the budgets are strict and people manage their yearly budgets. Not a lot of technologies to keep people healthy and measuring biological age. There's epigenetics, there's telomeres, there's the pheno age. So how can we standardize all this? And I think this is where the vision of Hevolution is critical, because it's like a buy-up, extra money coming outside of the budget of the Ministry of Health, saying how can we help policy? How can we help unify a unit of measurement of health? And how can we fund technologies so we bring true solutions for reimbursement in health? What we did in our company, we said, a lot of people are working on potential supplements or drugs for longevity or health span. We took the nutritional approach. And why we took nutrition? Because nutrition is the only product you consume every day of life, 3 to 5 times per day, the day we're born to the day we die. It determines the microbiome in our guts. It determines the epigenetic reading on our. So it's literally one of the most important determinants of longevity. There's five pillars for longevity, right? Nutrition, number one, exercise, stress, sleep, and happiness or social capital. And there's a competition between nutrition and social capital being the top two most influential out of those 5. So it's fascinating how we all eat every day, all of us every day, and no one put enough science to say, what should we eat to live long? This is the approach we took. We started developing food for longevity. We're the first. After 23 years of research now, we put 18 universities together, Harvard, Hopkins, Mayo, Stanford, etc. We have launched the very first product for longevity called Prolon for promoting longevity. It's a fasting nutrition. And it's the first patented product for longevity and the first product launched. We launched it actually in Dubai 2 years ago, and we're bringing it to Saudi. So we're very proud of that because it solved at least one of the first solutions. Is there something we can fund? Is there something we can reimburse? And now for the first time in the US, the Blue Cross Blue Shields, the Aetnas, the others are talking about to reimburse the product. And here we're in discussions about reimbursement as well. So that's a positive hope that there could be a technology brought in nutrition to support longevity. We're also tailoring nutrition for diseases. I mean, Mr. Fairuz talked about chronic diseases. A lot of the people probably in the centers that they look at, they already have diseases, but they already eat, but they eat every day, right? So today, on average, we live a good 30 years of life sick. The problem of longevity is we're living, I mean, we used to say long sick. We lost half a year in the US, so now we're living shorter, sicker, longer. Right. We cannot even say longer sick. It's shorter, sicker. And one of the ways we're tailoring food as nutrition is to also help reverse or induce a remission for some of the chronic diseases.
Now you've spoken, and a few of you have spoken about the role of data in this decision making. And I think that this is a great lead into what you have been doing through your organization. how do we make more data-driven decisions, whether it's in our clinical care, whether it's in the therapies that we prescribe, the genetics, or even to help inform policy and decision-making?
Yeah, as you can hear out itself, everyone is trying to attack the same problem, in 1,000 different ways. Health is a complex problem, a super complex problem. And if you reduce that and think only from the clinical point of view, then even in the clinical space, how do you truly differentiate between opinion versus decision? And opinion and decision is where the vanity and the science, differentiate or commingle, whatever way you want to think around it. My take is healthcare as of now is still very data hungry. The quality of good data in healthcare doesn't exist. The continuity of the data doesn't exist. On top of that, there is all kind of challenges around the privacy and the security issues, all genuine issues. But as of now, the status quo in the sector is more around not doing anything is the approach. My session and take to the healthcare and learning this, I've spent around close to 18 years in the world of finance, and I've seen how finance sector has truly changed because of using data as a utility and building extremely large-scale data architecture on which you can build all of these insights. And I personally think for healthcare and for Healthspan to be legitimate, a great sector in which we can build right science, we really need to super invest into building right data at your fingertips. If you don't invest into that, not only the clinical data, but also quote unquote, as we are getting into the digital space, the digital architecture of the data, the infrastructure of the data, you will find that the insight that we'll build will be very, very weak, And as the evolution of AI becomes more, reality for future, data will become a core utility on which all of this can be done. So I treat data as a utility architecture, as a foundational base on which true science can be built or true care protocol can be built for the future.
And I'm just curious, I have an opinion, but I'm curious what yours is. How do you see that funding coming in? Where do you think it needs to come from? What are the drivers for that?
So I personally think it will be done by an entrepreneur, but it will be primarily large-scale funding has to come from a state. It is an infrastructure as a need that a small scale it can be done by the private capital and the venture capital. But at a large scale, it has to be a government and the state funded. Because if it is the state is not involved, then it always have the gap between the private and capital, and the scale will never be there. So think of it this way. The bridges and the roads can't be built by a single entrepreneur. Bridges and the roads and the buildings of this nature can only be extremely well funded only by a state.
Are there some other views of that? I would personally say the other area that I'm very interested is investment from business, given that wellness has such an impact on GDP and the productivity of a workforce. I really kind of love the idea that businesses begin to understand this and invest in it.
Let me take the first take.
Please.
And 10 years back when I started this company, mental health was not quote unquote a sexy topic. It was COVID had not happened, it had not become a reality, the taboo is still very high, the ignorance is still very high. And I was approaching it and I was way too thick-skinned to really take on this problem without knowing anything about it. Ignorance played in my defense. 10 years into it, we are probably the only company which is not into care delivery, purely on the data, and have put close to 100 million behind it and has close to 100 plus scientific abstracts to show the value of the data. The reality is to really take it to the next level. I can see myself putting more than $500 million or $1 billion behind it to really take it to the next level. So the question becomes that how do we really make this as a legitimate large-scale investment, on which you can build the whole infrastructure of success is the key question that we should tackle on.
Very good.
Maybe I can add to that. Look, I think I have a similar story. If I went 4 years ago to an investor and said I want complete data sets, I want all my in-clinic data, lab data, diagnostic data, and I want to capture everything in the cloud. You know, continuous glucose monitors, sleep data, whatever, stress data, activity data. You know, that part is a cost center to me today. To a business, that is not generating any additional revenue from fee for service. You know, even though the outcome is superior when you combine them together, you can create a care model, but nobody would have funded me for you, and actually nobody funded us. You know, and we had to self-fund ourselves completely. And to this day, you know, people go and look at it and say, well, you know, why don't you just stick to the provider model, the stuff that gets high margins, your labs, your drugs. There's a lot of drugs in metabolic health. There's a lot of testing. That stuff makes money. This behavioral change aspect where you have to hire a whole bunch of people, you know, to monitor health, a whole bunch of devices that you have to give out for free. You have to build the tech infrastructure because that data now becomes part of the clinical data. You know, that is not reimbursable today. So it's a tough play to try to cover all angles in the traditional VC or PE type of investment today.
That actually leads in also to the genetic side, and this is maybe where the public-private component comes into play.
I want to add to the point where they describe the data. Well, data is very valuable. It's a very powerful tool to advance the clinical care and moving from the traditional routine clinical care into a more personalized approach. Speaking from our experience, having large-scale population-level data and genomics and multi-omics, and then moving into the translation, our main challenge was not only in generating the data, having the right fund, having the infrastructure. The main challenge now when we are moving into clinical care and translating the research outcome was having the right expertise to translate that into an actionable, clinically actionable decisions and decision making. This was quite challenging because the science is rapidly evolving, the technology is rapidly evolving. Finding the right expertise to translate that into a clinical actionable decisions was quite challenging. However, to tackle this program, speaking from our experience in Qatar Precision Health Institute, we create a full program. We start as a pilot study where we have the clinicians involved with us, the researchers are involved, the bioinformaticians are involved, and also with the decision makers, the governmental officials. We create a program and then we assess and evaluate the outcome of this pilot study and whether we have the enough evidence to translate that into clinical actionable decisions. And we do a full assessment for all the healthcare departments involved in translating the research outcomes and whether they are ready to translate that and to adapt that within the clinical routine.
So we've talked about a few different components of this care model and the data behind it. Are there particular technologies that you are particularly interested in that you think are emerging or underutilized? Obviously, Ihsan, you've employed a number of these within your clinic, but I'm curious among the rest of the panel here, what is on the horizon and what are we not looking at yet?
No, I a little bit alluded to it, but I'm very passionate about the biological aging clock, right? Because in diabetes, we know we measure blood glucose, HbA1c, a payer comes and pays for it, whether cash pay or whether, you know, in Alzheimer's, we have metrics. In cancer, we have PCR, overall survival. When you come and you talk longevity and health span, if you don't measure, and you know, Qatar is very commendable, they're actually starting mapping the entire genomics. They're measuring on top of the genome and then the omics and then the biological metrics, so they can actually start measuring. If you don't measure, as Peter Drucker says, you cannot manage. If you don't manage, then you cannot improve, and then you cannot come up with policy to determine. So one of the major challenges today is how can we unify the biological aging clocks, because there's epigenetic, there's telomeres, there's the phenotypic aging, etc. And is the unit of measurement of health span is the biological age. And how can we fund And this is where you mentioned the private sector or the public or somewhere with Hevolution where they're coming together, is how can we go and unify and find what is a gold standard unit of measurement of aging, so that then we bring investors, then the payers, then you can measure, you can improve, and the entire ball of longevity and Healthspan can start rolling.
Very good. And Ryan, I know we had some conversations about some of the work that Mayo is doing on the digital side.
Yeah.
Can you speak to some of those?
Yeah, so I think a lot of the digital offerings are pretty exciting. A lot of the wearables, right, that we're employing within our longevity space. For us, it's always, you can capture a bunch of data from these new digital devices. How do you interpret it? How do you get the information to the clinician so they can act on it, right? We've utilized ways to do that and train our health coaches how to interpret some of the wearable data. We've employed wearable EEG for both for psych indications, but also sleep. These are great wearable devices, can sense your brain waves, compare with your iPhone, can deliver meditation packages, right? So we've done a number of studies there. We're also looking at VR as well. How can we employ VR technologies to help downshift a lot of the stress that is ongoing with us that we know can alter Healthspan. So those are some of the exciting ones. Also some of the AI tools that we're now looking at for our physicians, right? So it may not really impact Healthspan per se, but things like ambient listening. How can we have the ability to allow the physician to spend more time with the patients? Because to me, it's all about time. We're not going to get reimbursed for some of this. If you give us a little extra time in the room with the patient, we can go through a lot of these concepts. So we've employed ambient listening, where you'll turn on the iPhone and basically the AI and ambient listening will record your conversation with the patient, interpret it, and then input into like a history of present illness and also an assessment and plan, saving us 10 to 15 minutes per encounter, allowing us to get to that next level of talking about resistance training, talk about nutrition principles, talk about some of the things that we want to deliver to the patient, but we just don't have time.
Well, that's fantastic. And I know we talked a little bit about sort of the patient or consumer experience in all of this as well. I think my experience, I think the experience of many here has been that often the interface with technology, particularly on the healthcare end, is not the most engaging experience in many systems. It's not designed with the Net Promoter Score in mind. I know that you're doing some work on that, but let's talk a little bit about sort of what that clinical experience might be. Is there a future beyond Zoom visits, and what are people thinking, and where this will go, and how we'll engage with our communities? Maybe I'll start with Nathaniel. I feel like this is an area that could be right.
Yes, it is. I want to come back to what I said earlier. What is normal? Because we're all wearing Whoops, rings, and Apple Watches, but we are converts already. We don't need to convince ourselves. But most people, they don't want to hear about that, or they will wear their Whoop for a month and then they will drop it and they will change. So we need to make things work as normally as possible. So forget about robots, forget about tech that is too invasive, forget about things, especially for the older crowd, that you need to recharge every day. We need to find ways that are fun. So gamification is interesting. If people have as much fun as looking after their health data as they have as scrolling on TikTok, for instance, obviously that will improve. And focus on things that help to enhance the human component of care. So when we look at tech, that also probably answers, we look at wearables. We cannot pass it, but we don't look at robots, and we look at everything that helps to take care of the job that is done on the backstage. So freeing up time, human time, from our caregivers, from our therapists, from our psychologists, from our nutritionists, so that they can spend quality time, pedagogical time with our residents, with our customers. What we don't want is tech focusing on replacing the human connection, because actually human connection is a component of healthy longevity, as you pointed out. So this is really the paradox for us. Tech is meant to be invisible so that the human component of the relationship can come back. And at least this is how we see it. And the question then is, how do you democratize it? Because tech on a large scale is cheaper than human capital. So how do you train the right people? How do you optimize the processes so that the doctors, the caregivers are able to deliver their service in an efficient manner? And so this is the second help that tech can bring, is making these people more efficient.
Yeah. Just to add to that, I think one way we can push the agenda of preventative health is just looking at our existing workflows. Maybe I'll give an example of something we tried, a calcium score, a CT calcium score. Okay, how do you get a CT calcium score today to be as routine as possible? Today it's not routine. Today you have to be at risk. You have to be referred to a cardiologist. Cardiologist does whatever, an echo. Echo goes to a stress test. Stress test goes to an insurance approval. Insurance approval goes to a CT. By the time you get there, you're probably in your 50s, maybe more. And that's if you're lucky and you're actively chasing. There are wonderful technologies that can essentially do that entire flow, bring that CT right to the beginning and make it a screening through a retinal scan. So we've implemented a AI diagnostic, FDA approved retinal scan that gives you the same calcium score as a CT would. Now, that's a few dollars. And you can run it on everyone, risk or no risk. And that's one of the ways we can bring a lot of that preventative health, by just looking at existing workflows, break them, change them. These systems exist. Unfortunately, they're done by quite small companies. They go through the process, but they're not your GEs or your Philips or your Siemens. You got to figure out how to integrate them. But there are some great solutions in the diagnostic space that can democratize a lot of the more difficult insurance-based procedures.
Yeah, I think those are all fantastic points. I think the question we'll come back to is sort of the data on some of those. And I think we would all agree, I think there's tremendous promise in all these. How do we build the data quality to get there so that we can say that there's evidence-based decision-making in those? And I think that's one of the really interesting problems here. And maybe we just have to be open to change and trialing some things that are sort of on the edge, that translational end.
Yeah.
Do you have a thought on that?
The reality is that this science will keep emerging. Whether it is nutrition, whether it is exercise, whether it is sleep, whether it is even cognition, meditation, any one of those, you will certainly have the emergence of science of all nature. And by default, it's almost impossible to build something that will be a holy grail of everything, So you'll always have this episodic solution to any subset of the problem. The real beautiful is, how do you normalize all of this data and put them into a standard which is research grade or the science grade? And the beautiful out there that is really had developed is the compute power. The compute cost has really gone down. The cost of integration has really gone down. And that technology is very powerful, because then you can really make it actionable very fast. And the cost of compute is not a deterrent anymore. So what will be always as a deterrent is the friction as to what you can build and what you can adopt. The adoption technology will always be hard, and this will always be episodic. But the refinery is becoming sharper and sharper and sharper. And that's how I look at, whenever I think from the macro point of view, that it's hard to solve this. This will be a function of payment model. This will be a function of behavior. But this component, the technology, is a massive enabling component, and the space at which is moving is a very, very solid S-curve, which is very, very, very positive.
I'm going to come a little, I'm sorry, were you? Please.
I want to build on that. There are organizations that collect data, generate data, and monetize data. It's insurance companies. And I don't have time to talk about this, but the insurance companies in China, I would encourage everybody to look at what they've been doing. They've managed to vertically integrate healthcare, financial products, senior living, and longevity, so that they are able actually to centralize all this information. They have their own computing power, they have their own analysis team, and they're able then to create product that financially makes sense and that benefit ultimately their clients. And so I think at some point, if we don't solve the relationship with insurance companies, we will always struggle with availability of data unless governments take over, and who's paying.
So I will counter argue that also that truly in healthcare, innovation will always happen in the care section, people who do care.
Agreed.
Because they are the frontier and they are the one who is touching the patient directly or indirectly, whether it's, the payment model is always the hard part of the problem to solve. Until the payment model doesn't get solved, it doesn't become reality. It stays at a very substandard. Payment model, as much as private is great, is the public sector is the largest sector always. And whether we like it or not, payment model is never innovative. And hence the challenge in healthcare, that how do you create something scientific that is great, gets paid, and innovative,
I was going to bring the conversation back a moment ago to sort of that personal interaction that you had described. And I was going to go to Ihsan because there was something that we spoke about earlier that was so interesting to me about your model. You talked about how you bring the education up front, you help individuals configure their devices, and then it can become more virtual afterwards. Can you speak a little bit more about what you've done at GluCare about that?
Yeah, sure. I can run you through what a patient's journey looks like, and in clinic and out of clinic. So in clinic, let's say he's a diabetic, a patient with diabetes. They don't see a doctor. We baseline a set of tests. So they go they draw their bloods, 30-minute turnaround time. Then they do a liver scan, a retinal scan for retinopathy, a brachial index, a pseudoscan, a ECG, a body composition analysis, in a series of tests, all taking about 20 minutes. So that has saved them probably 3 to 4 visits, in a normal, typical setting. Then they go and see a physician, and all results are ready, because a lot of these are point of care, and labs are real time. They see a physician. Physician goes into presentation mode and presents to them on a large screen. This is your liver, this is your kidney, this is your thyroid, whatever it is. Because I need that education process to start in the clinic, and I need that seamless workflow to happen. Otherwise, out of clinic, I'm not going to get any compliance. So the behavior is going to be poor if I don't actually have a seamless in-clinic experience. So then we download our app, give them devices, pair all their devices, a continuous glucose monitor, wireless weight scale, wireless cuff, Oura rings, and then we pair them with a team, a personal trainer, a dietitian. We do nutrition AI integration, educator, and then we observe over a course of 3-6 months all these parameters, and we have different engagement points. We see insights, we take action over that insights, we turn that action into a discussion that happens to them, which leads to an outcome. Usually per quarter in between the visits, that's where the behavioral change happens. It's about 15 engagements in between visits.
And these are all virtual?
These are all virtual. The physical ones still happen every quarter as per the American Diabetes Association guidelines. But we've figured out that if you have about 15 engagements, regardless of who's engaging, whether it's the physician, the personal trainer, the dietitian, the educator, the psychologist, if you have about 15, you start seeing some major changes in outcomes. Compliance varies. Some people are super engaged. Some people are very passive. We try not to give any diets, any exercise regimens. Instead, we baseline them when they leave the clinic to see what is the actual activity levels, what are the stress levels, what are the time and range for glucose, what does it look like before we action it. Now, a question we get is, how do you get insurance to pay for all of this? Well, there's a formula we have. We generally know what insurances approve and what they don't approve. Obviously, they don't approve of what happens outside. The behavioral change does not get reimbursed. But a lot of the in-clinic activities do, and we just essentially created packages to be able to do that very seamlessly, and it's worked. Within a year, everybody is below A1C of 7. No one's asked to be put on a diet or a heavy regimen because it doesn't work for most type 2 diabetics. We ask them to follow a certain diet. They just won't listen. So we'd rather start with their own baseline and then do incremental changes with time.
Thank you very much. And let's move for kind of the remainder of our session to speak about some of the beyond the strictly medical aspects of this. I'd like to talk a little bit more about nutrition, lifestyle, predisposition with family, and sort of what we see there. What do we need to put in place to get these to be part of the experience?
Well, I'll go back, and it's a great question, and because it's beyond the clinic, and I'll go back to the 5 pillars of longevity, right? We talk about nutrition, exercise, stress, sleep, and social capital. When we track centenarians, and we study a lot of people, centenarians 100 years and beyond, the most common denominator they have actually was their social capital, going back to, because when you're happy and well established, you sleep better, you stress less, you eat healthier, and you exercise. And the second most important factor was nutrition, because that's, again, the only product they consume every day. Then comes stress and sleep and exercise. So we got to look into all of those, and I think this is probably one of the secret of the success in the clinics in the UAE, is they're trying to help them measure, and when you measure, you manage, and then when you manage them with the coaching and with the accompaniment that they do, they're helping them work on all these factors. We took the angle of nutrition, and because we found out that there's no true science done till today. We have hundreds of billions of dollars in pharma, hundreds of billions of dollars in drugs, but we have almost, very few dollars coming up to, and I always ask people, what is the one company you trust eat your food from? Every day you eat. You all want to live long. What is one company you would buy your food every day from because you trust they're clean, their formulation doesn't push the aging factors, especially insulin and IGF, and you trust, and if I ask 100 people, you get 100 answer.
Yes.
So we decided to be that scientific company of the word for longevity and study what kind of food formulations people need to eat to live a healthy, long life.
And Dr. Wadha, from the genetic end, what do we need to put in place to get more of the genetic information into the clinics?
Having the genome data from the population level, well, there are 2 ways to have the right genomic data to create the preventive programs, or whether in longevity, Healthspan, or on disease-based preventive programs. Either focusing on the population level genome data or disease-based genome data, both pipelines will help in creating the right measures and the right workflows to tackle the diseases and to tackle the health of the population. The way we approach the health of our population in Qatar is by sequencing the Qatari population, and as I was talking behind the stage, the data that we collect is not only from the Qatari population. We collect data from the Qatari population and from long-term residents who lived in Qatar for 15 years and above. Having the representative data that representing the community and understanding the genetic predisposition to certain diseases that put the health burden in our healthcare service will help develop certain preventive measures to tackle these diseases.
Thank you. And in the last minute we have, I'd like to just briefly go around, and if there's one thing that we pay closer attention to in Healthspan focused care from these diverse perspectives, what would it be?
For me, brain health. Sleep and brain health is going to be a key component of Healthspan.
Thank you.
Yeah, look, I would tackle the payer. The payer is the problem. The payer forces us to, to have conversations like this, trying to find solutions. But unless we solve, that reimbursement problem, we're only going to be talking every conference about, all these great tools we have, but very little execution on the ground.
Thank you. Dr. Hurt?
I was going to probably say the same thing. Payers, I smiled. I think payers are probably our biggest problem for implementing Healthspan more globally.
Thank you. Nathaniel?
I think payer has been taken already, so I will say motivation. How do we make people behave consistently and be willing to do so?
I would say the similar thing is community engagement, engaging with the community and make them trust in science and make them trust in Healthspan and longevity.
Thank you very much.
From my standpoint is a unit of measurement of Healthspan. How can we define the true age of a person? Because 90% of us will die out of the 4 age-related health conditions: diabetes, cancer, Alzheimer's, and cardiovascular. So for me, that's is where everything starts.
Well, thank you very much. This was a fantastic panel discussion. I appreciate everybody's help and participation today. And with that, we'll end today's session, but some great ideas moving forward. Thank you.
So, welcome to the Investment Exchange. As an important part of what Hevolution is doing is fostering innovation through research, but also through investment. We're starting companies, we're investing in early stage companies, and we're partnering with pharmaceutical companies, research and development partners, and very importantly, other investors in the global life science ecosystem. Now, there are a couple of panels here at the Healthspan Summit where what I would call traditional life science investors who really focus on drug development in a very standard way are coming into the Healthspan space. But Healthspan is so broad and so all-encompassing that there are investors who come at the space from different perspectives, all interested in healthy lifespan, all interested in health and wellness, all interested in some way in the biology and science, but from different perspectives. And we've gathered some really special people for you here today to talk through what they're investing in, what they're excited about, and what brings them to the area of Healthspan. And I'll introduce who they are, but I'm going to let each of them talk about their funds and their perspective, and then we'll get into the Healthspan stuff. So starting at the end to my left, your right, Vijay Pandey is the founding general partner of A16Z Bio and Health in the United States. And Amal Sarva is the managing partner of LifeX Ventures. Hannah Mamuzka is the CEO of Alva 10 and the managing director of 10 Edison Capital. Mark Berniger is the co-founder of Maximum and Longevity Investors in Switzerland. And Zach Lynch is the managing director of Jazz Venture Partners. So why don't we go in order and have everyone take a moment, talk about what your fund does and what you mostly look at, and then we'll get into the Healthspan part in particular.
Yeah, hey everybody, my name is Vijay Pandey, the founder of the A16Z Bio and Health Fund. So when I started the fund 10 years ago, the thesis was that technology broadly, whether that would be machine learning or other areas in computer science or in engineering, would impact life science and healthcare. And the fund was designed to invest in both life science and healthcare, and we've basically done it 50-50. Part of the benefit of having that mindset to invest in both is that we're really trying to think about what's in patients' best interests. And so certainly going after disease is a key part of it. But Healthspan, once you think about delivering healthcare, Healthspan comes to mind very rapidly. And also in Silicon Valley, I think there's a ton of interest in longevity broadly. When I look at longevity investments, I think there's sort of two versions of it, what I would call the weak form and the strong form. The weak form is that, well, we all know that aging has comorbidities into many diseases, not just Alzheimer's, but even cancer and type 2 diabetes and so on. So investing in the biology of aging will give us insight into those therapeutic areas. The strong form is that understanding aging could actually do something to slow down aging or even reverse aging. And we're starting to see companies doing that. And that's super exciting, although that's starting to get much more into science fiction and maybe what we could maybe hope to see in maybe 10 or 20 years. But companies of that scale would be obviously truly revolutionary, and we're looking in those areas as well.
Amal?
Wow, Vijay, I mean, I can't believe I agree with every single thing you said. I mean, we only launched our fund 2 years ago, but I guess it was on the exact same premise. I hope we learned a little bit from the work that you guys did. So my fund is called LifeX. I'm a longtime entrepreneur. I actually did my PhD at the same place where he's a professor at Stanford. And I did cognitive science, and then I left the field. I started a bunch of companies, some of them kind of big, like one's a mobile phone company that was the fifth biggest one in the US called Virgin Mobile. And then another one, which was like a real estate company, prop tech company, global number 2 to WeWork, 0 to 400 million in revenue, and the real estate business. But a couple years ago, after that company got bought, I thought, oh, let me go back to my academic foundations and see if maybe it's time for scientists to use computers more than they did when I finished my work. I think the only software I used was something called LaTeX, and then also Microsoft Word, and that was it. And now all these years later, they made the vaccine on a weekend on a laptop, and I thought maybe it's possible to actually start tech companies. And so what we do with LifeX is
well, it's called LifeX, Life Extension, and the idea was maybe technology will help us accelerate innovations and also accelerate deployment of new things that might help us all live longer and better. That was the idea. But we wanted to just do the tech stack. We just wanted to do AI and software and data and networks and really never touch drugs themselves, just to kind of be very selfish. As I was mentioning to someone a bit earlier, we're sort of like day traders in the longevity world. We're not investing for a 20-year outcome. We're trying to find things that might actually work within 12 months or 24 months, and usually it's not a drug. But I really do agree with Vijay's way of thinking about it. There's like the weak and the strong form, and I'm sure we'll talk more about it. The moonshots, but also the basic ways you die. There's 5 ways you die. If we can make progress on that, then we make progress.
We'll talk about the 5 ways you die in a little bit. Hannah?
Thank you so much for the invitation to join. My name is Hannah Mamushka. My fund is called 10 Edison Capital. By background, I'm a molecular biologist, scientist by training, spent about 20 years in the diagnostics industry. The past 20 years have been this incredible innovation in diagnostic technology. When you think about our ability now to not only diagnose disease, but assess risk, use risk information to prevent disease, to figure out who to screen, to optimize care delivery, we can really transform medicine, we can transform care delivery in the way that is personalized to patients. You know, we talk a lot about precision medicine and personalized medicine, which I think are actually keys to longevity. Because the key to longevity is really understanding, you know, everybody's different disease biology, what diseases patients are at risk for, why they're at risk for them, and how can you mitigate that risk? What can you do to prevent onset? What can you do to detect something early and intervene early for that particular patient? I don't think that, you know, we're going to have a one system fits all for everyone, because everyone is different. Everyone's genetics are different, epigenetics are different, their exposome is different. And we need diagnostic tools to be able to understand that and to be able to really improve patients' lives. So we focus on diagnostic tools at those clinical junctions where physicians don't have a way to make a decision right now, and where a new diagnostic tool informing care can really change the trajectory of patient care and change the healthcare system economics.
Interesting.
Yeah, hi everybody. My name is Mark Bernegger, based out of Switzerland. I'm a tech entrepreneur, started my first internet company in '99 right after college, and since then built and exited several of my own companies, among other 2 listed companies. Personally following the space since 2009, and 4 years ago I started a group called Maximon. We are a venture studio building and financing companies in the field. We also, as Amal said, focusing mainly on the low-hanging fruits. We give in US dollars the first 12 million per venture first ourselves, and try to identify fields which have a measurable scientific-backed impact on humans but can generate revenues today. As an example, our very first company, Avea, it's a longevity supplement company where we also have some patents on some of the ingredients, is now quite exactly 3 years old. And we do now roughly 2 million per month. So even by focusing on measurable elements, we focus on businesses where we can do boring revenue. And yeah, that's what we're focusing on. And thanks for having me here. I'm here the second time, and it's really astonishing to see what's happening here in the region.
Zach.
Yeah, thanks, Bill. Hi, Zach Lynch here, founder and managing partner of Jazz Venture Partners. We're a San Francisco-based venture capital firm, really investing at the convergence of science and technology with a specific focus around human performance. And so that leads us to look at deals in sort of the overall health space, wellness, but also productivity, because how we all work and spend our time has a profound impact, actually, on our long-term health span and longevity. You know, we are slightly in the biotech space in several of our 50 or so deals, but primarily, like much of us on this panel, really like to look at opportunities that can generate returns within a decade, not 2 decades. So I think we'll have some interesting conversations around that.
So, you've heard about tech. You're talking to folks who have more of a technical quote, capital T technical background than a capital B biology background. And yet, here at Hevolution and in this meeting, we're spending a lot of time talking about mitochondria, talking about proteins, talking about diseases. So, I'm curious, how do you, Mark, think about how the areas that you're looking at talk to biology? I understand you may not be wanting to get your hands wet in a lab mucking about with cells, but you still have to talk to biology here.
Yeah, naturally, and it's a lot about the framing. I can tell you again the example of this supplement company, right? When we started, we tried to really position and referring to all the studies and everything which is available. And then, unfortunately, we realized that many people, especially the end customer, they just want to have some immediate effect. So only by using the term mitochondria, you will lose, I would say, 95% of people on the street, right? So maybe similar to the early days of the internet, if you talk, and also, for example, digital assets, Bitcoin, if you talk too technical without really helping or explaining what is in for you as an end customer, you will lose many of these people. And that's why I think to really make longevity, health span, something tangible for the broader masses, I think we also maybe have to change a little bit the framework. I mean, if you have a scientific conference, naturally you talk about the science, but as soon as you go outside, many people, they don't care too much. It should be scientifically proven and backed, but they want to see what's in for me. And I think that's something maybe also in a format like here, which is still a little bit missing, I would say, in the space.
Good. So we've brought up the idea of supplements as opposed to allopathic medicine or antibodies. You and Mal have talked about something that both can generate revenue. I presume that means create value for patients and customers within a couple of years, not a couple decades. What sorts of things touch the biology in a way that can have an impact on Healthspan?
Yeah, lots of things. I mean, the conversation with biology, I mean, it's what I was thinking of just as Mark was explaining his view on this is sometimes something big happens and then it has lots and lots of consequences. Like you invent the GLP-1 or you invent the iPhone. Like take the iPhone for a second, right? It's not a drug, but someone made the iPhone, they're super good, they made lots of money from that. But there were so many other incredible implications from that about different apps you'd make, networking, things for telcos, what kind of databases, what should be native, what kind of chipsets should be inside. And so someone makes a drug, a GLP-1. I think it changes the world. It changes insurance. It changes the way medicine is delivered, telemedicine, how is it done in person, testing, the biomarkers that you're tracking on your phone suddenly change. The stuff happening upstream around synthesis and manufacturing, things like compounding in the US about how people manufacture certain drugs. None of those is the GLP-1. You know, Novo and the Lilly people, they have this drug, but all around it are technology-enabled transformations. Some of them are biology, but I mean, the business that I have been in over the years is finding ways for tech to change or attack or shape insurance and prop tech and mobile phones and smartphones and other electronics and devices and all these things. And I think all of that is relevant exactly just on that one thing, on GLP-1s, but then even more broadly around many of the things that we discover around longevity. Let's say it was mitochondria. I mean, I think there's so many interesting places to go and be busy selling tools to scientists, selling tools to doctors, and then also to patients. They can be just software things. So selfishly, we're being a little short-termist. I think in the world, it's always some people are shorter and medium and longer, and there's a role perhaps for each of them. You know, it's not a nice thing to call myself a day trader of longevity, but you know, I'm looking for things that help move everything forward, right? So more people come next year to this conference, not 10 years from now. So that's my view a little bit.
Excellent. You mentioned diagnostics.
Mm-hmm.
How does that intersect with what we're talking about here?
Well, I think diagnostics are actually the first thing that needs to happen when we think about all of the interventions that have been talked about today. we need to figure out, who the patients are who we're going to treat. So if you take the GLPs as an example, we know that for some people GLPs cause weight loss, and for some people GLPs really rectify diabetes, and for some patients they really reduce cardiovascular risk, but not everybody. For some patients the SGLT2s actually do it better. Some patients would be fine on a statin. We need to think about, like, what are the goals? If you think about the use of GLPs in a high-risk cardiovascular type 2 diabetes population, your goal is to reduce not only, from a cosmetic perspective, but from an overall health perspective, your goal is to reduce the risk of a serious event, heart attack, stroke, loss of a limb from diabetes, all of those things. If the drug that you're giving gives you some of the effect, but not all of the effect, you've missed the potential to really impact the patient's life and change their longevity. So understanding from a diagnostic perspective what's working better, I think, is key to bringing all of that together.
And so to go a tiny bit deeper on that, are you talking about investing in companies that are developing tools to predict which people will respond in a certain way to, say, GLP-1s?
Yes, I mean, there's actually a lot of data out there already. There are actually already some diagnostics that are already on the market that have that data. Some of them that have tens of thousands of patients of that data that either show the benefit of GLPs across all of those clinical questions, or the difference between GLPs and the SGLT2s, or the difference when you tailor just the use of standard lipid statin therapies using genetics. That data is actually out there. Those diagnostics are actually available. But those are the types of diagnostic tools that we do look to invest in.
But taking it out of just GLP-1s and adding in the supplements, I mean, there's a burgeoning market right now in human performance around people doing 50, 60, 70, 100 biomarkers. I think Function does now. And then they wrap you in, you get those biomarker tests every 3 months, and then you get your supplements to improve or, support different ways of helping your body function better. I mean, I was actually stunned this morning when I heard that the Buck was working on a 100,000 biomarker test. You can only imagine that that's an interesting opportunity, because imagine the number of supplements you'd have to take if you had 100,000 biomarkers. So, I mean, I think that is part of a layer on the Healthspan longevity space that, as Amal says, is sort of a tighter feedback loop. Whether or not it solves the problem or actually expands it, time will tell.
It's definitely something people want to pay for. Testing and
They absolutely will pay for it.
Because people don't pay for apps.
Well,
Nope.
especially testing gets a couple things. One, there's actionable things to do afterwards, and that actually gives patients a sense of agency in their healthcare, which is often missing.
Right.
So I was going to go, VJ, to you next and ask 2 things, not related. One, maybe 3 things. One, do supplements work?
Yeah, depend on which ones you take, and so I take a bunch of things, but like, take a simple example. I take vitamin D. So my skin is a little darker than yours, and I don't get as much vitamin D as other people do. That is an example of adding something which my body would have otherwise.
Yeah.
So it could be vitamin D. It could be hormone replacement therapy, which could be either testosterone or estrogen, but either one puts back the endogenous stuff. That's actually one thing which, even if you just did that, could have a huge impact towards Healthspan.
And it's certainly not, it's controversial in its own way, I suppose, but it's not, that's certainly not considered kooky.
Yeah. Well, but I think the key thing is, when I think about Healthspan, there's not doing stupid things, right? So like, you don't smoke, you don't do things like that. Then the second bucket is, let's replace the stuff that's missing. And the third bucket is, let's add something that wasn't there before. So you mentioned Function. Mark Hyman, one of the co-founders of Function, a functional doctor in his own right, has this great line about GLPs. He's like, diabetes is not an Ozempic deficiency disease. So the concept there is that for that third bucket for putting things that wasn't there before, I think there should be a high bar for that, for why we're doing that versus going after the first two buckets.
Yeah, excellent. So each of the sorts of companies you've described are clearly different. They're all facing people sooner than a traditional life science company. As you think about, and I'll ask a couple of you this question, as you think about developing these companies for Healthspan, I'm not going to say for Healthspan indications, I mean for Healthspan, is there something different about the way you need to approach supporting these companies and developing products, or do you think of them more as, well, I have a diagnostic company, I know how to do diagnostics, so I do that, or is there something special about Healthspan? I'll start with you.
I think in diagnostics in particular, there's a lot of cool technology, but you have to think about what is the problem that needs to be solved and how does it need to be solved. And I think that's where people think that investing in diagnostics is really challenging, because I think a lot of the time we get founders and early investors get excited about the potential of a technology, and the first application kind of goes into the market and sort of gets jammed in there without really thinking, what is the problem that needs to get solved, and is this technology really a fit? And that can be simple things that we don't always think about, like turnaround time or patient workflow or patient experience, physician workflow, all of that. So we think a lot about really trying to align the technology with the problem to be solved in a way that can accelerate patient access and time to market.
So you brought up the patient experience. Amal, the kinds of companies you're investing in, is the patient experience important, or is the chips experience important? Hardware, software, wetware?
Well, I definitely think the patient, it's hard to sell longevity to people. The same way it's hard to convince the FDA that it's an endpoint. Most people do not consume a tiny amount of something for their whole life, hoping that somewhere on the other end of it they'll notice. Right. So you have to sort of narrow their own felt need down to something they actually care about. Like, I'm really curious if I'm dying of cancer right now, I want to get this test. Like, there's some painful desire that needs to be resolved. So I think that is at the heart of the companies that have worked really well. They're sort of giving you some feeling of satisfaction in the nearer term, and I think that's why it's kind of, I don't know if there is a large mainstream longevity company yet, I guess. I mean, they sort of work by helping you lose weight and other things that are more tangible in the near term.
Right.
So maybe I'll stop there, but I do want to talk to you about chips and all that, because there are some weird ways to go once you start meditating on this problem area, and yeah, maybe some chips.
We'll come back to that in a moment. Vijay, your portfolio is large, and you described earlier that you do have companies, you're investing in companies that are more biologic and those that are more digital. Is there a common theme or connection between them, or are they really, we're wet, we're dry?
I think one common theme is that they're all platform companies. And so they're all building on technology to be able to not just spin out an asset. But you asked earlier about sort of the patient experience. I think one of the things about Healthspan that might be different is that often we think about the consumer as a patient, but the consumer obviously is a payer. And in the language of insurance companies, payers, and providers, in the end, we are the ultimate payer of whatever happens. And I think if people could have an informed decision for Healthspan and a sense that they actually would do something, maybe you could measure something to show change. That combination, I think, would get attention. And we're seeing a huge rise in direct-to-consumer healthcare with that in mind.
Absolutely.
To build on that a little bit,
do.
because some of this is just marketing, if we're just frank about it. Healthspan, longevity. We've got a company that just launched called Eternal, and they are focused on the athletic span, which is basically Healthspan, but they've coined it for the athlete. So that if you want to be a 70-year-old, who wants to run marathons, you should be using Eternal supplements and taking their biomarker test, and our coaching system will get you there. And that's the company. Is that longevity? Yeah. Is that Healthspan? Yeah, but they don't really say those words. They talk about the athletic span. And it's just marketing, right? To that consumer.
So got that.
Yeah.
Now, here's my question about that. So I'm an athlete. I want to be running marathons when I'm 70. I'm open to the idea that coaching could be important. Maybe supplements are important. And maybe some other stuff too. You're packaging all of it together.
Yep, VO2 max, all of it. Constantly adding to it.
Is there one part that's more important than another?
No, I think it's actually the solution. You're trying to solve this problem for that individual consumer. Yeah.
Mark, how does this conversation intersect with the kinds of companies that you're investing in that face patients?
Yeah, I think one point Vijay said before, I think, is that it has to be somehow actionable and you have to do something. I mean, for example, we also run a clinic like many others, and sometimes you have the VO2 max, you have the blood test, you do the DNA analysis, all the stuff, but then what's happening next, right?
Right.
First, maybe you should improve or you could be better, but that's not really helping you. Maybe you even feel worse, right? So that's also not the outcome you want to achieve. So that's why I think quite important after we have all the data and all the outcomes, what does it mean for you as an individual, patient, consumer, payer, whatever. And I think the whole impact starts, right? Because if you just measure it and visualize it, that's the first step, but that doesn't bring you to an increased health span, right? So for us, ultimately, what really is the trigger to achieve a measurable positive result? That's always something we're heavily focusing on, and that's maybe also sometimes still missing. And I never heard this term you just mentioned, but maybe it's a pure marketing slang,
right?
But just if I could tell you, if you do this and that, and you will do marathons for 4 more years, even by not fully understanding why you should do this or that, it has a higher impact on you because you can somehow focus on a goal, right? So the marketing, I think, is necessary to then have the scientific element who really brings you to this next level.
But some of this too may go like, I don't know if you know the history of Tesla. They first put out the Roadster, which is kind of a niche product, and you build a company off of that. Maybe the number of people in America, let's say, that want to do the performance stuff is 1 million people. It doesn't sound like that many people, but if you can make $1,000 a year from them, that's $1 billion top line. That's still something valuable. And then you extend to the general population from there.
Well, and in listening to you all, maybe there's a lesson in here for anybody interested in health span innovation, which is, and I think you alluded to it earlier, getting people to take a pill for a long time to avoid an outcome that they can't predict, can't measure, and they don't have right now is for sure challenging. We know it's challenging because today people aren't compliant with the things that they know they need to do. Taking blood pressure medicines, taking cholesterol-lowering medicines. So irrespective of whether you're developing an app or a diagnostic or a supplement or a combination of all three, is the special sauce giving people something to measure and track that does something that either they feel or see?
Well, I think so. He was alluding to that, but I actually want to hook up on that marketing idea. Like, the term of longevity is kind of new. People didn't really use it very much a few years ago. We're already at the point where we're worried it's turning into schlock, but we should kind of appreciate it. It's like quite amazing that people are thinking about boring stuff like prevention and long-term care. And I mean, the conference is full of like real substantive inventions that are like about to change everything. And the public knows about them. It's like many of the top podcasts in the world, the covers of the magazines, many of the best bestsellers.
it's kind of cool that like the world cares and is paying attention and is perhaps reshaping to a level of like personal hygiene around how to live, where maybe the comment of like, oh, taking a pill every day for 30 years is stupid, maybe that's like out of date. Maybe we are all full of 10 or 20 or 50 pills in our, I mean, I have a bunch in mine. Maybe I'm wrong about that. Maybe we are ready to like adopt en masse, well beyond just 1 million people. So I think it's a wonderful tailwind. It's a reason for existing here, but it's also pulling us all forward.
But I think we know too that there's abundant data that shows that when a physician prescribes something and says, I'm prescribing this because, and this is started in oncology, you have this marker, so you're getting this drug, then the patient doesn't just feel like it's sort of trial and error of I'm going to give this to you and I'm going to try it and see if it works and if it doesn't work. So I do think that that aspect of agency and of the patient feeling like I am taking this because of my biomarkers, of the knowledge about my disease, gives them a different reason than just, I don't know why I got prescribed this, I don't know why I'm taking this drug. And I think that gives them more ownership over the change management as well.
I mean, a beautiful example of that is the Oura Ring, right? 2.5 million of these sold now, 500 million in revenue last year, growing very rapidly, but it's only just scraped the global market opportunity. And why does it work? Why do people like it? First of all, 7 days, it just sits on my ring, my ring finger. I don't even know it's there. I've replaced my wedding ring because it just like makes it easy. And what do I get? I get biomarkers every day telling me, oh, I shouldn't have had that third glass of red wine, And actually, after 2 years of wearing it, I stopped having that third glass because I was finally done with it, And I'm like, that changed my behavior. And I think that biomarker feedback to your personal self is absolutely critical to getting people to change effectively over time.
Great examples. We'll come back to a couple pretty fundamental things in a moment, but let's switch to the other end of the process. So various folks today and tomorrow will talk about who the players need to be for a Healthspan ecosystem to really flourish. You need venture capitalists, you need entrepreneurs, and you need pharmaceutical companies to take this innovation the last step, do big registrational trials, market the drugs. These are different sorts of companies. What is the final common pathway for these companies? Are Lilly, Novo, and Pfizer going to buy these or partner with them, or is there another way that you can realize value for your investors with them?
I think the first thing that has to happen if we want major change is on the regulatory side, such that you could have Healthspan as an endpoint in a trial. If you do just that, then companies will come because you can get into market and so on. And you'll see a flood of investment and innovation. And I think that actually could happen in the US in the current administration. That alone would change, I think, be a dramatic change.
Amal, what's going to get your companies sold?
Well, we don't really do drugs, right? So we try to find tech stack for pharma. And that's sort of been a fool's errand for like most of history. There aren't a lot of big companies, like technology companies, that make their money selling to pharma. But it's kind of got to be out there, because in every other vertical that tech showed up, the dominant company is tech. It's the biggest automotive company or retail company or advertising company or finance company or whatever. So it's got to happen. And just in our Fund 1, there's like a couple of things that I think are really, really promising and quite cool. And to the pure technologists among you, they will sound so boring, but to the bio people among you, your mind will be bent by it. AI infrastructure and data. So unique pools of data from weird places that no one ever could get the data before. In a world where the models are amazing and they can understand anything, you have to give them stuff that needs understanding. And so if you can find the only survivors of impossible cancers and you can do the 20 different multiomics on them, you've got a monopoly on the multiomics on the only survivors, because there won't be any more survivors for a long time. They accumulate so slowly. So unusual pools of data, I think, is amazing, and some of those companies that we have are doing great. And then AI infrastructure, you would think all AI infrastructure is the same. It's all just like Amazon and NVIDIA, and well, kind of no. I mean, if you're doing financial trading between London and Chicago, you need it to be fast. But if you're doing genomic analysis with a terabyte per patient on 1,000 patients that are all cited in Cambridge, you kind of don't want to move the data. You'd like to do it all right there. So already the network typologies of different use cases are very different. In biology, there's different reasons for different kinds of infrastructure. A couple of our companies are doing amazing because all they do is a decentralized type of compute. When people look at those companies, they don't even think they're bio companies, but that's how we found them. And I think they're very non-consensus and very unusual, but I think that's sort of how it works in venture. That's how you find amazing stuff. I mean, the most obvious idea in the world, AI for drug discovery, is really tough, you know. I don't think we have any edge there. But some of these funny, weird things, they may end up being the biggest ones.
Cool. What do you think?
Yeah, maybe I can give you a personal example. I mean, my last company was in the digital asset space. We started in 2017. Back then, the space was borderline shady. We raised roughly 50 million only from individuals. No VC was investing in this space. We became the first fully regulated player. And fast forward 4 years later, the company was acquired by the German stock exchange, a 30 billion listed company. So a field, an industry which was perceived as unserious, completely out of any regulatory framework, in a matter of a few years became a target of some of the biggest financial players. And as we know, I mean, today we might hear from some news as a reserve currency. So the journey of something like the internet or the digital asset space, I think could be, and that's one of the reasons why I'm in the space. At a certain moment, you have a tipping point because you have the right entrepreneurs, the perception changes. In this space, you have the science, you have the data, and the end customer who is really willing to switch from a, I would say, sick care system to a preventive care system. And I can't tell you right now in which phase we are, but I wouldn't be surprised that we will look back in just a few years from now, and we will be all surprised why somehow the shift was not happening. And it's always easy before the tipping point, because nobody knows when the tipping point is, but after the tipping point, nobody will understand why we lived in this old status quo. And I think we will see a very similar development here.
Excellent. I'm going to return to a topic, and I'm not going to ask either of you two about it, because I know you know a lot about it. I know you got something
Indian
to say.
people?
Sorry?
Is it about Indian people?
Only indirectly. Very indirectly. But good. No, AI. So there's a lot of noise about AI. There's a lot of noise about AI in biotech. There's a lot of noise about AI in drug discovery, in drug development, in drug delivery. And there's a lot of noise about AI in Healthspan. And frankly, there's a lot of noise about AI here in Saudi Arabia in a lot of different ways. So, Zach, AI in your companies and your fund, interesting, uninteresting, critical, irrelevant?
Fundamental.
Say more.
It's like software was, 10 or 15 years ago. If you don't have it, I don't even know what you're doing, really. We have a half dozen AI drug discovery companies in one way or another. They're not generalists, they're hyper specialists. Kind of like Amal was saying, we've got someone reading all the world's ancient texts to figure out whether or not you can find one plant across, ancient civilizations that has some sort of similar outcome, and we think we found a new Advil. Very interesting. There's, a company that's highly focused on rare diseases, because if you can do single gene flips and get that data, then you have very, very solid data to be able to build new models off of. In the cell and gene therapy space, we've got an opportunity there to build sort of a collaborative, no-code, cross-platform, cross-lab solution that aggregates all the data and runs it through your machine learning algorithms and actually helps you build cell and gene therapy products that are more manufacturable, but that's not really something that anyone's kind of really thinking about. So I think that, again, it's like infrastructure. It's not, are we going to actually make the molecule to treat Parkinson's, to what Vijay was saying. So yeah, I think it's fundamental, and it's fundamental across all of our companies, except for companies like Magic Mind, which is, a sort of a health shot that's trying to replace 5-hour energy, but they'll figure out some AI spin.
Mark, what about you?
Yeah, definitely a big topic. I mean, I'm not the AI specialist, but maybe the example you brought is definitely right? It's like in the earlier days of computers and also the internet. I mean, I started my first company 99 in the internet space, and it was hard to hear. We sold it to a listed publishing company a few years later, but the same companies back then literally told you in your face that this internet is a fad which will disappear again, right? And I think we have maybe a similar development when it comes to AI, but I'm definitely not the specialist in that, but you have to use and adapt it. So maybe it's not the question how important it is, it's more the question of where you can really have today a real added value out of it.
Great. So taking a step back, thinking about the advances we've made in healthy aging, healthy lifespan, we'll talk about what we've accomplished in a minute, but I'm curious to start first. What do y'all think the dead ends have been? Where have people poured hype, money into healthy aging, longevity, and hit the wall? And in retrospect, it's obvious they would have, but of course it wasn't then. What do you think?
Well, in my space, I think the biggest miss right now is Grail, which is a cancer screening company that has had a lot of hype. They're doing blood-based cancer screening. Everybody wants cancer screening easily. Everybody wants it for everybody. Everybody wants to detect cancer early. That's clear. I've spent almost 30 years in cancer biology. But the way that they have sort of approached the market has not been to go after the high-risk population. It's really been to go after the people who can afford to pay $1,000 for a test. And so if you think about the continuum of cancer risk, you're at more risk if you don't go to a PCP, if you don't keep up with your screenings, if you have a high BMI, if you smoke, if you have a number of chronic conditions. Those don't sync with the high economic value population that's going to pay $1,000 for a test. And so if you look at, what I think would be the miss is going, the right sort of thinking, but the wrong target population, where we have this data. I mean, speaking of AI, we have the ability to look in EMRs, look in EHRs, look in claims data, and identify all those patients that are at high risk. Identify them based on their genetics, based on all of these other factors. You take the Grail test and you put it in that population, you have a completely different value proposition. Because now you're identifying all of these patients who who don't have any screening options, who may not be compliant with colonoscopy, or who can't take 2 days off of work to go for a colonoscopy, and you completely flip it. And it was really a missed opportunity. Again, great technological concept applied to the wrong market and wrong product market fit in a different population would have been a completely different story.
Zach, what do you think?
I mean, not to talk about supplements again, but I think for a decade, without the feedback of the diagnostics, we're just awash in nothing. And I think now...
but you think it's different now?
I think it's very different now. Because it's closed loop, and you can see the changes, and it can evolve with you. And that'll keep you with it.
Now we'll go back to the Indians.
Yeah, I think maybe it's easy to pick on telomeres as being something that people are excited about.
Yeah,
but maybe that's more effect than cause, or maybe noise.
Well, that's a great example. There's a lot of that out there.
Yeah.
We do science. We observe something in living things. We have a framework in which we understand what it is we've seen, and then we make a projection. And how often do we take a biological observation and say, that must cause something? And how rarely does that thing actually end up causing that?
Or it could have a common cause, right? I mean, so it may be an effect. We just know there's a correlation. And even if and maybe it's a noisy correlation, so not that great of a correlation at that.
I'm kind of captivated, though, by these dead ends, all the hallmarks of aging. I mean, I don't think they're dead ends. I mean, I think one of them might be right, maybe 2 or 5 of them are right, maybe in concert. It's kind of an amazing thing that somewhere in the last 10 or 15 years, people came up with some candidates for the master of aging, one of those things. It's kind of amazing because in the years before that, I don't think we had any particular theory or any particular idea. And the fact that there are 10 or 12 kind of plausible candidates, like fasting, it's all about autophagy, or it's all about immune dysregulation, or about DNA copying errors. the idea that you could get yourself excited that one of those things really is the main thing, that's kind of neat. I mean, of course you're going to crash and burn on a lot of those, and we may not get to an outcome on those soon. But to me, that's one of the most exciting things about longevity, and I think that might be why longevity is so hot, because people sort of feel it's in their grasp. If it was just eat less, exercise more, sleep more, have more friends, blue zone, that is so boring. I don't think anybody needs to hear that again. And I think these like transformative things around there's something captivating. But you know, you were asking about dead ends. Maybe they're all.
Well, I'll interject for a moment. I think people need to hear about those things over and over and over again. But clearly, all of us have to hear about them in some sort of context that'll get us to pay attention. None of us are pushing back on, gee, I don't know, getting more and better sleep and getting more exercise and eating right. That's all phenomenology. I think we've all bought into that stuff works, but none of us are doing it.
Yeah, well, that's definitely dead end, right? Like behavior change is so slow. If there's 2 million people with Oura rings and they've changed, it's not even 1/10 of 1%.
Yeah.
More the behavioral change maybe is more cultural than medical. Like stopping smoking wasn't just doctors saying we should stop smoking. It was no more smoking sections, no more smoking on planes. It was the whole cultural change. And I think, so some of this really has to come from the society as a whole.
There's a ton of really interesting literature about that that contrasts sort of, you can browbeat people into doing any of the things that we talked about and or into wearing your Oura ring and listening to what it says or taking supplements and taking the right ones. And people will be somewhat compliant. But it turns out a really potent change agent is making it easier for people to do the thing you want to do rather than hitting them with a stick and saying do the thing you want to do, or punish even more so than punishing them for not doing it. So making things a little bit easier works better than punishing bad behavior. So I think it's interesting to think about in our technology-enabled world that we're clearly building, how can you lower the friction of doing all the things that our companies want them to do?
I think in the US at the moment, we're less likely to have a period of more sort of central encouragement for things, just to be, I don't know, euphemistic about it. But I think maybe the opposite is kind of a cool opportunity. It might be easier to bring things to market, whether they're supplements or drugs. And it's already been happening over the last few years. Right? FDA has been approving more drugs, and this latest blockbuster pain drug, it only was like months from the start to the finish. But you know, maybe in this little period of chaos, there'll be like a lot of cool new things that people try out. Because I do worry, I mean, I'm not an MD, right? I'm just like a science person. And this idea of like do no harm, like zero harm, when there might be an immense benefit, I have never really felt it in my own bones. I feel like there's immense benefit, and we really slow things down to do no harm. And so maybe if the guys in charge for the next few years want to take a few more chances, we might see some amazing things.
So I mean, on that note, like we're beginning to see a bunch of peptide therapy companies that are selling direct to consumer. That's kind of that next gen way of, you know, putting stuff in your body and seeing what the results are. And I'm not sure, you might have some problems, but we'll see.
Well, certainly to use the L word instead of the H word, the
love,
that love. Too. The good for your Healthspan. The longevity world is full of people willing to take clear risk when there are doctors and the FDA and everybody else who knows, quote knows, are telling them, gee, I don't think that's safe. People are talking with their own budgets, they're talking with their own bodies, and they are experimenting on themselves. That's for real, and we could scold them, or we could figure out that there's some wisdom in there somewhere.
Or we could help them.
Or you could help them.
Or to better instrument and better observe risk, yeah. And I think there's also like a geopolitical opportunity in that, like here in the region, where maybe under the right sanction and auspices, you might move faster in certain dimensions.
For sure. So along those lines, let's turn to the future. So you've talked about what you're doing today. You've talked about where you think people are going. If we came back here in 5 years, what do you expect will be different? What do you think you'll be surprised that's different? And what will you be disappointed that's not different?
I think we'll continue to wear more comfortable clothing. I think that's a global trend. I think drinks will continue to evolve and become a way of supplementing our existence in a much more profound way as a delivery mechanism of health. And the thing that I think will not be around that we think will be around is a focus on eating right.
Okay, interesting. Mark, what do you think?
Yeah, 5 years is a long time frame, but I think it's also many things will happen around, again, the framing, what you said about smoking, right? I think maybe the biggest trigger is still not what your medical doctor tells you, but what you should do or want to do because other ones are doing it. And when you look at the younger generation, also, for example, in my organization, right, there's a completely different perspective on health. And not because of longevity or they want to live longer, they just look at health as something very personal, sometimes maybe even religious. And I think that's something which becomes far more relevant and maybe in the tailwind of this development also helping many of the things we're doing here. Because again, I think you need a broader change in the mindset because most people know what's healthy and not, and they would even know what they should change. But maybe they don't want to do it yet, and I think this will change dramatically in the few years.
Fascinating. What do you think isn't going to change, or isn't going to evolve, or isn't going to work?
Yeah, good question. I mean, maybe the food and exercise is still something. If you have certain preferences, even including smoking and drinking, maybe you just don't want to change. But not a clear answer to that. I have to think about it. But normally, these are the unexpected things, right? So it will be exciting already to see what's happening in a year from now.
Yep. Hannah, what do you think? 5 years, I chose 5 years to be long enough for some biology to play out, some technology to play out, some behavior to play out, but not so long that it's just science fiction.
Yeah, I mean, I think, in the next 5 years, especially in the US, the population that ages into their mid-40s and early 50s is the population that's had access to data longest. The older generations just sort of accepted whatever they were told to do for their health, and now we are entering in generations which are requiring more healthcare, but are more comfortable with their data. And I think they're going to be asking more and more of the healthcare system about how decisions are made. They're not going to just accept sort of the average rules. They want to know why it's being applied to them. They want to know how they can adapt things for them. They're going to question things, and I think that we see that change somewhat. I think that change is going to be very significant over the next decade as this group ages into more screening age and more an age of using more healthcare. I think the thing that I'm worried is not going to change is our insurance, Medicare payment mess of a system. In the U.S., I think that the Saudi region, KSA, has a very different perspective on how they think about payment here and how they think about value and longevity and paying for things over time. In the US, we have not been able to get over that yet. And if we don't get over that, then we're just going to run into this barrier of we have a certain class of people who are able to pay for all of this innovation and biomarkers and biofeedback and adaptability, and then we have another group that is not able to pay for it and their insurance is not paying for it, and that is going to create a massive health gap that's just going to widen.
Oh, interesting and scary.
Very scary.
Amal, what do you think?
I have a handful of, I mean, remember that iPhone thing earlier, like one big thing happens and it reshapes everything? I have a handful in mind that are a little bit like that. I think that everyone's going to live a lot longer on average. 5 years from now, it'll be measurable, it'll be decisive, at least just because of the GLP-1s, maybe other stuff. But I think we are just into the health span boom. Like, we're talking about it as if it's a theory. I think it got invented a few years ago. Everyone's going to have it. And we will measure the impact. I think another one, which I think is my own little fantasy, is there will be a drug of that scale every year for the next 5 years. So 5 years from now, there will be 5 more things on the scale of GLP-1s, and I think I already banked my one for this year. It's a pain drug that disrupts the neurons or whatever. Cell and gene therapies, where they take your cells and make you some new cells and give them back to you, and it changes your body. Basically, they gene edit you. They're already more than 10% of the spending in the US in pharma, these infusions and stuff. And I think there'll be one on every street corner, and you'll be 50% of people will have had some kind of cell and gene therapy by then, maybe for minor things like wrinkles or gray hair or something like that. And then maybe the last one is drugs, bad behaviors, cleaner versions. You'll have like nice tobacco and alcohol and whatever. And I think we're already in that trend. Like all these gummies and marijuana and that stuff, like we're on our way to like clean and polite bad behaviors.
Is that going to be a good thing or a bad thing?
I mean, you just wanted to know what would be different, but
a little bit of both.
A little bit of both? Yeah, I think that's probably right.
Yeah, so for me, I think one of the things that I feel confident we'll have in 5 years is some version of AI doctor in your pocket on your phone, and it'll be connected with maybe new types of measurements that will be done, and the key thing will be sort of giving you advice every day. And so the fantasy, it's the thing you wake up, it's the first thing you look at, because it's giving you advice for what you should do that day in terms of eating or workout or really just changing your behavior. But that coupled to that, I think part of what drives Ozempic is not its impact on type 2 diabetes, but its connection to 7 deadly sins, like its connection to vanity probably. Yep. And so I think there'll be other drugs that will connect to one of those, but will have hopefully side effects that are pushing health. And why do people take things? Well, drugs are easy. Working out's hard.
Right.
But maybe one of the hopes, and maybe more positively thinking about it, is that if you're extremely obese, working out is really hard. And so something like Ozempic could actually give you a jump start and put into that mindset, in my mind, driven through, let's say, an AI coach or doctor, we can hopefully get people to get started and keep on going.
Fabulous. Well, thank you all. This has been super interesting. And any last words? Wisdom, caution.
What do you have for us, Bill?
So, to pick a couple things from our topics, what I have yesterday is haranguing people about diet, exercise. Most of the recreational drugs in the world aren't so good for you. You should wear seat belts. Those are the sorts of things that impact lifespan and healthy lifespan today. So we had them yesterday. They're impacting them today. And we've hit the ceiling, clearly. At Hevolution, we're investing heavily in let's generate some new knowledge. More the better. Hard to argue about that. We're investing in let's really invest in translation, since there's a big valley of death between interesting laboratory observation and something that seems to actually impact health. And that is whether that's a biologic observation, a physical observation, a chemical observation, or even a sociological observation. So what's almost the taxonomy of translation? What is the outcome that we're looking for that will actually make humans into big mice for the purpose of actually predicting an outcome? We need to invest in that. And then I'm going to skip over all the stuff we're doing today, because we're doing a lot today on investing in companies, starting companies, looking at companies that are combining data, interpretation of data, and biologic observations. Of course, we're investing in interesting molecules. That's interesting. It's important. We have to do it. But for the purpose of a conversation like this, skipping over that to how do we get things delivered to people? That's something that, that we have to do tomorrow. Not next month, not in 5 years. Between now and tomorrow, we have to figure out better ways of delivering the information, the technology, and you all are finding some sticky ways to do it, which is great. But we have to put that into a context of our healthcare system and the way our healthcare system works tomorrow, not the fantasy one of the future. So we've got to work on that. Well, thank you. This has been fascinating and really fun. I appreciate it.
Thank you. Wasn't easy.
Yeah.
That was